Thank you, Dr. Gleave. I'm Anthony. For those that may not have met me, I'm one of the R2s, and it's my pleasure today to be presenting my grand rounds on the current landscape of screening for renal cell carcinoma. Obviously, I don't have any disclosures. My objectives for today's talk are to go through the principles of an ideal screening program, reviewing the epidemiology of RCC, and applying the principles of screening to RCC. As well as at the end with some time to discuss screening within specific populations. So obviously, screening currently for RCC is not performed. There's no guideline recommendations for this to be performed. But I think it's important for us as urologists to understand the principles of screening as they apply, and particularly so that we are able to have a discussion with our patients and our colleagues about screening, but in the consideration that we as urologists also are managing conditions for which there's a fine balance between screening to identify earlier onset disease with the balance for potential harms related to overdiagnosis and overtreatment. And the poster child for this, of course, is prostate cancer, which we have a lot more experience with. But there are other cancers in Canada which are screened for currently, including colon cancer, breast cancer, cervical cancer, and lung cancer, as well as prostate cancer, although there's controversy among all of them for when they're rolled out. But the gist of it is that a lot of these other cancers do have a higher incidence rate compared to RCC, and there's a lot more data to support screening in this population. Now, the principles by which screening tests are evaluated are based upon Wilson and Jungner's initial criteria after they published a paper in 1968, which is adopted by the World Health Organization. And these are the criteria that are still utilized to this day to evaluate screening programs, although there are some researchers who have suggested more contemporary methods of monitoring this. But essentially, the aim of screening is to detect a disease at a point when it's as of yet undiagnosed and at an earlier stage, thus that intervening will be able to improve outcomes for the patient in terms of mortality and quality of life. And screening tests need to have a high sensitivity rate to ensure that as many patients with the disease are captured, but they also have to have acceptable specificity rates in order to prevent overdiagnosis. And so I'd like to go through just briefly each of these criteria. So obviously a condition that would be amenable to screening needs to be an important health problem. That is, it needs to have a high enough prevalence, and it also needs to have a large number of patients that have mortality related to the disease. We don't want to be screening for something that is not killing people. Additionally, we need to understand the natural history of the condition in which we're screening for, including how it develops from more latent to declared disease, in order to select for patients that in whom treatment would be appropriate. There also should be an appropriate period by which screening can be performed and identifying tumors at a stage where intervention would make a difference in outcomes. And there needs to be a test that's able to do this with reasonable sensitivity and specificity, but it needs to also be acceptable by the patient that's undergoing the screening, such that there's high enough attendance rates for screening. And finally, there needs to be treatments available for conditions that are detected through screening. And these treatments need to be agreed upon from those that are treating it as to who to treat with disease. And finally, within the context of our health system, this needs to be considered on a cost effectiveness basis when you consider the costs of screening with the costs of the disease progressing naturally and detecting it at potentially a later stage. And so all of these considerations are important when it comes to discussing screening. So we need to understand the epidemiology of RCC before we can discuss screening here. So we'll move on to this as my next objective. Now, within Canada, the incidence of RCC is about 7,500 cases per year, with it being more common in men than women, approximately 2-to-1 ratio. And it is a relatively common cancer, but it's not as common as many of the other cancers which are screened for. The overall 5-year survival for patients in Canada is approximately 71%, and I'll go into that later, that it looks quite different for patients that are in later stage compared to early stage disease. RCC also is, I was surprised to find out that it's one of the most lethal genitourinary cancers when you look at it from a cancer-specific mortality rate, in that there's a higher number of patients who have RCC that die of the disease when you compare it to prostate or bladder cancer, for example. And unfortunately, up to 20 to 30% of patients who are diagnosed with RCC present with metastases, that is a stage 4 disease, and this is associated with significantly poorer outcomes. When we look at the risk factors for RCC, there's a number that are identified and established, including that of advanced age, male sex holding a 2-to-1 increased risk over females. Smoking history, obesity, and hypertension are well documented. And there's also the increased risk with the end-stage renal disease population, particularly related to them acquiring renal cystic disease. But there's also a separate incidence within the renal transplant population as well, regardless of time on dialysis. Finally, there's also a strong family history component, both within the hereditary syndromes, which make up about 5 to 8% of all patients with RCC, but also separate from the hereditary syndrome population. Those with first and second degree relatives have a higher incidence rate. And there's additionally some occupational exposures which have been found to be related to increased risk, particularly trichloroethylene, which is a solvent. Now, the incidence of RCC, as we know, has been increasing steadily over the past 20 to 30 years at a rate of staggering over 3% per year. Now, it's multifactorial, the reason for this, but it's likely a result of true increase in incidence, that is, increase in risk factors such as the aging population, which is exemplified here in the graph as the most prevalent, the cohort with the highest rate of increase, but also a increase in the diagnosis of renal masses based on the widespread use of abdominal imaging. There's also a strong correlation worldwide with the GDP per capita, and this may be a result of diagnostic access bias, which is where patients who are part of a more developed nation may have greater access to medical care, and therefore for increased imaging, which results in increased detection. If we look at the worldwide map for incidence, we see that developed nations such as North America, Europe, Australia tend to have the highest rates of RCC. And we can compare that to a similar map where we look at the Human Development Index. So again, it maps pretty closely to those nations that have the highest, most developed nations. And the additional finding here is that, for example, continents such as Africa which are more developing and have lower rates of RCC, also tend to have much poorer epidemiologic data, and so it's a lot more difficult to determine whether we are really picking up all of the potential cases within that in these countries or continents.
Anthony, so is it really actually lower then in Europe than it is in North America, or is this just a registry kind of problem?
This is a registry. These are registries. So overall in Europe, it does appear that the registry epidemiologic data is lower. But when we look at the incidence of RCC, they're pretty similar in Europe. But despite the rise in incidence rates over this time period, we've actually seen relatively stable mortality rates, which is a concept known as a treatment disconnect. And this can be a result of a few biases, which are important to highlight when we're discussing screening. The first of these is a lead time bias, which is by the overestimation of a survival detected through screening by earlier detection, but without any actual improvement in the time of mortality. And this can be compared to another type of bias, length time bias, which is that screening tends to detect malignancies that are more indolent and therefore have a longer period by which they can be detected, whereas more aggressive cancers tend to have a shorter time to symptoms, which may present outside of a screening program. And therefore, any screening program tends to detect more indolent cancers and therefore overestimate the expected survival with screening. The authors here also suggest that there's a potential risk for over-treatment, let alone over-diagnosis. And this is a study performed in the United States of Medicare, fee-for-service Medicare beneficiaries of 15 million patients between the age of 65 and 85. And they compared the rates of CT of either the chest or the abdomen, which included the kidneys, over a 4-year period in 2010 to 2014. And they compared these rates of CT between different hospital referral regions, and they correlated it with the rates of nephrectomy. They found that overall, those referral regions that have higher use of CT were associated with a higher rate of nephrectomy. And they concluded that imaging 1,000 patients was associated with 4 additional nephrectomies. There's a few problems with this data. It's highly correlative, and we actually don't know the cancer-related outcomes. That is, whether performing those 4 additional nephrectomies improved the outcomes for these patients. But it is an interesting correlation. And we have to consider these risks of overdiagnosis and potential overtreatment when we're considering the fact that advanced stage RCC still has very poor survival rates, which is the impetus for wanting to detect it earlier. When we look at I was really surprised to see that from stage 3 to stage 4 disease, the 5-year survival drops dramatically to 12.4%. And it's also important to note that these are not a few patients that are in stage 4 category. 9,000 patients in this group is 25% of all of them who are within the stage 4 cohort. And so this is obviously an important health problem. And another way of looking at the burden of cancer is through determining the number of years of life lost. And this is data, national level data from Norway in 2012, where they used previous data over the past 15 years to determine the number of years of life lost per cancer. And they use this based on the age of diagnosis with the cancer, number of cancer-related deaths, as well as the expected life expectancy. And it would suggest that kidney cancer actually has a relatively high burden on the number of years of life lost amongst all cancers, and particularly when we compare it to other genitourinary cancers. So obviously, there is a rationale that for screening of RCC, given that it has an increasing incidence. The majority of patients who are present with RCC may be asymptomatic and therefore leading to a delayed diagnosis, and that more than 25% of patients have metastases at the time of diagnosis. But the real question is whether we can improve survival by detecting RCC at an earlier stage, or whether this is outweighed by the potential risks of overdiagnosis and overtreatment. And so with that, I'd like to move on to addressing the rest of the principles of screening in the context of RCC. And so this just brings us back to these criteria that we use to study screening tests. And I'll be going through each of these considerations for RCC. Now, when we consider the natural history of RCC, unfortunately, RCC does not have a premalignant state by which we can identify and treat to prevent progression. For example, in comparison with colorectal cancer, where screening aims to detect polyps, which may be treated at an early stage, and thus removing the risk for malignant transformation. And we really have very limited clinical parameters to determine progression or predict tumor progression within RCC. And really the only way that we have is to follow them based on size and to identify almost retrospectively, once tumors have grown, that these ones are likely of more aggressive nature. And so most of the data that we have for the natural history of RCC is actually based out of the active surveillance population for those that we're monitoring. And this really limits the type of data we have for natural history because this is a different patient population often. Having said that, there is a prospective cohort that was recently published here in 2020 of 608 patients during a multi-center observational trial in the UK who were followed from the time of referral for diagnosis of RCC to a median follow-up of 4.8 years. And they identified that the majority of patients with RCC were identified incidentally, that is 60% of the time, but that those patients that were identified incidentally tend to have smaller tumors and lower stage disease. So if you looked at this from another perspective, if we're catching masses incidentally, they tend to be small renal masses at lower stage. And the question is, which of these are going to be, we know that some of them will be more aggressive and progress on, but some of them will be indolent. On the other hand, if we're waiting until patients present with symptoms, then they tend to be associated with higher stage disease with poorer outcomes. And this becomes the diagnostic difficulty of RCC. Within the population that are followed for active surveillance, this tends to be an older population or those with limited life expectancy. And within this population, there seems to be a consensus of a growth rate of around 3 to 4 millimeters per year. And it's proposed that active surveillance is safe because they tend to show low rates of metastases over the study periods that are typically around 2 to 3 years of about 1 to 2%. And I just wanted to highlight one of these multi-center prospective trials that I believe we were a part of, but led by the Toronto group, where they followed 209 small renal masses in just under 180 elderly patients or those that were with limited life expectancy who had delayed treatment until evidence of disease progression. And the eligibility for these patients was that they had to have a T1A, a small renal mass less than 4 centimeters, with no evidence of nodal or metastatic spread, and that they also were unfit for surgery due to either advanced stage, comorbidity, or refusal of treatment. And it's important to note that the mean age in this cohort was 73 years, which is likely to be a different patient population than that would be a part of any screening program. But their primary outcome was assessing rate of progression, that is either small renal mass increasing to larger than 4 centimeters or tumor volume doubling within a year or progression to metastases. And overall, their conclusion was that the rates of local progression are relatively low at 12% over the 2-year time frame, but even lower is the rate of metastases, with only 2 patients at 1.1% progressing to metastases. But when we look at RCC, we need to consider whether there is a period of time which is latent or early symptomatic in which screening could be effective. And so Fenton et al. Aim to determine what this period would look like by pooling the results of 5 studies that determined the prevalence of RCC based on screening. And this screening was for other indications, such as screening for lung cancer. And they identified over 16,000 total patients in the US who had undergone screening CT and determined that the screening prevalence for RCC in this cohort was 0.21%. And they were able to back calculate using this number, comparing it to the incidence rate, which depends upon the age of the population, but that this range for a period which would be considered preclinical would be from 3.7 to 5.8 years. And this is actually, according to other experts, a very reasonable sojourn time, whereby it's not too long to suggest that all tumors are indolent and therefore not worth catching, but that it's a long enough period for screening to intervene upon to make a potential difference. And I won't dwell on this topic too much because as urologists, this is we have plenty of experience with this, but overall there are accepted treatments for patients that have RCC with partial nephrectomy when feasible being the gold standard. And there may be a consideration that if we're able to screen for patients and diagnose them at an earlier stage, there may be a higher rate of nephron-sparing techniques being able to be performed. But obviously radical nephrectomy is also appropriate for patients that have tumors not amenable to partial nephrectomy. There's also other options, including thermal ablation for patients that may not be suitable for surgery. And the evolving role of active surveillance is also important because right now it's currently recommended mostly for patients that are elderly or limited life expectancy or do not want treatment. But if screening were to be performed, it would play an important role in differentiating between patients that would potentially be overtreated and also being able to detect patients that have more aggressive tumors and therefore would benefit from earlier treatment. There's also a number of screening modalities that need to be evaluated in terms of what would be the most appropriate for a screening test. Urinalysis is very commonly performed and would be very straightforward to perform as a screening test. Unfortunately, it's very limited by the fact that very few patients with known RCC actually have hematuria present in comparison, for example, to bladder cancer. And in this population from Korea, where they screened asymptomatic healthy patients over the age of 20 with over 56,000 patients, they identified that microscopic hematuria was present at a rate of about 6,200 in 100,000. Whereas when you compared that to the number of patients with RCC that were then found, there's only a rate of 5 per 100,000, suggesting a very low diagnostic yield. And this is just a more recent study that some of our residents, Taewon and Miles, were a part of. This large international study where they evaluated nearly 11,000 patients who were referred to urology with a suspicion for urinary tract cancer across 26 countries. And in this population, over 94% of them were referred with hematuria, but only 107 cases of renal cancer were actually identified with less than 1% of this cohort. When you compare that with nearly 18% of these patients with identified to have bladder cancer, there's obviously a low diagnostic yield with urinalysis. It would not be an appropriate screening test for RCC. The role of biomarkers, however, is important, be that from tissue, urine, or serum, and they have the real potential for clinical use in the future, particularly differentiating between indolent tumors and those that are more aggressive, but also within a screening context for identifying patients who maybe should undergo further imaging to determine whether they have a renal mass. But at this stage, most of these biomarkers are preclinical, but certainly warrant further investigation. Some of the most promising are these two biomarkers measured in the urine, Aquaporin 1, which is a water transport protein, and Perilipin 2, which is a lipid droplet protein, membrane protein, both of which have been shown in early phases to be increased excretion in patients that had renal tumors with nearly 100% specificity in that initial phase between patients that had disease and healthy controls. And the same authors, Morrissey et al., then went on to perform a larger screening population they determined using the same urinary biomarkers. And they screened they underwent a population of 720 patients who were seen in their clinic undergoing CT scans of the abdomen for other indications. And they concluded that this would be their screening population. They also collected urine samples from healthy control patients who were also self-selected by the authors in comparison to 19 patients that had urine samples detected who had known RCC. And they had excellent test characteristics based on sensitivity and specificity. But the interesting point was that among the patients, the cohort of patients that were undergoing CT screening, 3 of them were actually identified to have elevated levels of Aquaporin 1 and Perilipin 2. And these patients then went on to undergo their CT scan and were found to have renal masses, of which 2 were confirmed to be RCC. So it does suggest that there may be a role for these biomarkers to be evaluated further, particularly in the context of identifying those that would be appropriate to be screened. But this is about as far as they've come so far and require further investigation. There's also imaging modalities which could be performed. And as we know, the gold standard diagnostic test for renal masses would be CT. However, as a screening modality, it's limited by the fact that it has a high cost and risk for radiation. And given that we know the incidence of RCC is quite low, the risk of radiation exposure would outweigh this in a screening population. However, there is currently a trial being performed looking at, in the UK, looking at whether extending lung cancer screening CTs to include the full kidneys would be beneficial, given that patients we know lung cancer is already screened for in smokers in the age group of 55 to 74, and that whether the role of extending the CT to include the kidneys would improve the screening for RCC, but the results on this are still awaited. Finally, the most studied and most reasonable imaging modality for screening would be that of ultrasound, actually. Given that it's non-invasive, it's safe with no radiation exposure, and it would be inexpensive to be performed on a system basis. There's also evidence to suggest that ultrasound is well tolerated by patients, in that patients who undergo screening for AAA abdominal aortic aneurysms have high attendance rates with screening at 85%. But ultrasound has its limitations related to obesity, which we know is a potential risk factor for RCC. And for small masses, the accuracy is less than CT, particularly those under a centimeter. However, having said that, there are most studies do focus on ultrasound, given those previously mentioned characteristics. This is a cohort of asymptomatic patients in Japan, with over 16,000 of them, who self-presented for a health checkup with no other inclusion or exclusion criteria, and were screened with ultrasound for abdominal cancers, as listed above. In this cohort, the mean age was 47, and as I suggested, there's no other inclusion or exclusion criteria limiting these results. But ultimately, comparing kidney cancer to liver, biliary tract, and pancreatic cancers, the authors concluded that that screening for kidney cancer would be the most effective, given that it had the highest prevalence of these other cancers in their study and the highest positive predictive value. But it's important to also mention that pancreatic cancer, these cancers have significant mortality, much greater than that of kidney cancer, and so screening in this population is also questionable. This is a separate large-scale study performed in Germany within 2 cities of nearly 10,000 volunteers who self-referred or were invited for screening, with the inclusion criteria just being over the age of 40 without known cancer or renal disease, with a mean age of 61. Importantly, within this cohort, ultrasound was not performed by radiologists as it typically is here. It was actually performed by the GPs, internists, and urologists, which were trained on this and assessed to be competent, which obviously limits the external validity of this study. They performed renal ultrasound at 1 year and then in a second year as well over this 2-year period. And overall, the incidence of renal masses was only 0.1% within this cohort over 40 years of age, and they determined only 9 masses ended up being RCC. Having said that, they had a reasonable test characteristics with a sensitivity of 82% and specificity of 98%, but is limited by the low prevalence of the condition. So obviously, the prevalence of RCC is important when determining cost effectiveness. And so these authors here performed a meta-analysis of all trials, which were either screening for RCC or performing abdominal ultrasound for another indication and incidentally detected RCC. And of note, all of these trials were of non-randomized quality and were performed, despite the fact that this meta-analysis was performed in 2017, all these studies were from the years of 1980 to 2000, questioning whether they have contemporary relevance. Ultimately, they identified that the overall prevalence for renal masses overall was 0.36%, however, and that the prevalence for histologically proven RCC was 0.1%, although they conclude that this histologically proven prevalence may be an underestimate, given that not all RCC are histologically proven. So the same authors then used this data to go on and perform a cost effectiveness analysis for screening for kidney cancer with renal ultrasound. And they utilized what's known as a Markov model, where they determine all of the potential treatment pathways for patients that have RCC dependent on stage, and they incorporated a number of costs, including how much it would cost to screen, how much it would cost to treat each patient for treatment based on the stage, what the expected treatment outcomes would be based on stage and applied treatment, as well as follow-up costs and the cost to work up incidental findings. And one of the interesting details that they presented was that in the population of screening patients for RCC, that only less than 2% of this cohort was presented with stage 4 disease, which is significantly less than, as we determined earlier, up to 28% of patients who are detected with stage 4 disease based on standard of care. However, this begs the question of whether this is true downstaging of the disease with screening or overdiagnosis of small renal masses. Ultimately, though, they compared their results with the UK Health Ministry's reported willingness to spend up to 20 to 30,000 British pounds per quality adjusted life year on screening. And their results suggest that screening 60-year-old males would be the most effective, cost-effective cohort for screening, with the incremental cost effectiveness being under around 18,000 pounds. And it's important to note that the prevalence here of RCC, as you can see, which is about double that of comparable females, is the main reason that for the cost difference between females and males. And it begs the question, equity related issues, whether there was to be rollout of a screening program that was only focused on males compared to females. But it does raise the question that, whether it suggests that screening more specific populations, particularly those with risk factors, would likely be the most cost-effective way of performing screening, and further trials may be required to determine other risk factors that could be screened. So finally, just moving on to discuss screening with a particular specific population, which would be that of hereditary syndromes. We know that 5 to 8% of RCC are hereditary in nature, and that these are predominantly autosomal dominant syndromes. This is a group of the United States which compared the median age at the time of diagnosis of the 608 patients in their hereditary RCC program. They compared that with the general population who had RCC based on a SEER database, and they found that the median age at diagnosis for those with hereditary syndromes was 37 years compared to 64 years in the general population. And this is the data that suggests that we should be screening patients that have a renal mass younger than the age of 46, because this includes 70% of all hereditary RCC, but is overall less than 10% of all patients with RCC in general. But it's important to note that when we talk about screening for hereditary syndromes, that this is a different context than what I've been presenting so far, in that all of the guidelines here is the Canadian guideline for hereditary RCC screening are based upon patients who have already been identified to have a renal tumor and have other characteristics that suggest they should be screened for a hereditary component. And these are bilateral nature of the tumors or multifocality, as I mentioned before, age less than 46, and whether they have first or second degree relatives with a renal tumor. And there's a number of other clinical or histologic factors that should raise the suspicion and suggest genetic testing as well. But there's only the only cohort here within this screening group for patients that do not already have a renal mass identified would be patients who have a family member that already has this condition identified. So this poses a big challenge in that we're unable to detect early renal cancers that present with those with hereditary RCC based on any other screening at this point, other than if they have known family members or other clinical presentations. And so I didn't have time to go through each of these in detail, but I just wanted to summarize that there are some screening recommendations for those that have been identified to have a hereditary syndrome, and for identifying those that have renal masses. The most common here being von Hippel-Lindau, which overall has a lifetime incidence of RCC of around 70%. And therefore, the I guess consensus would be that annual screening with MRI should be performed, and some authors suggest starting at the age of 16. But and it's similar to Bird-Hogg-Dubé with the lifetime incidence risk of being 25%, that they also suggest annual imaging with either MRI or ultrasound starting from the age of 20. And both of these conditions should be, renal masses, should they be identified, should be followed under surveillance until about a 3-centimeter cutoff before nephron-sparing surgery is considered. And this is in comparison to hereditary leiomyomatosis in RCC, which, although has a lower lifetime incidence of RCC, it's associated with the much more aggressive papillary type 2 RCC, and therefore they again recommend yearly MRI as screening, and some authors suggest as early as the age of 10, but that early surgical treatment should be offered for these patients when they are identified to have a renal mass, given the aggressive and early metastatic nature. So overall, where are we at with screening for renal cell carcinoma? The authors here presented a nice review earlier in the fall, suggesting that at this point there's insufficient data to move towards a definitive clinical trial, which again would be required before we could suggest widespread screening. And they suggested that a definitive clinical trial would require 300 deaths related to renal cancer in order to meet power criteria, and that even if they were to do this screening within a high-risk cohort of 60 to 70-year-old smokers, this would require around 175,000 participants, so obviously a large-scale trial. So before even suggesting that such a large-scale trial should be performed, we have to consider that there's still a number of unanswered questions related to the particular screening criteria that Wilson and Jungner have proposed. Overall, RCC is an important health problem, and while we do understand the natural history in the progression tends to follow tumor growth, there is certainly room for improvement in differentiating those that will continue with indolent disease and those that have more aggressive nature, and this will be the crux of suggesting screening in the future. There's also a need for biomarkers to assist with determining those that are either early stage kidney cancer or differentiating those again with indolent or aggressive disease. And overall, there needs to be further cost effectiveness and evaluations once screening is performed in these larger scale prospective trials to determine whether they would be cost effective, but also to consider the potential harms of screening and consider this in the context of everything. So these are a number of the proposed ongoing areas of interest that should be considered within this population for screening of RCC. And ultimately, the question still remains whether screening will actually lead to a survival benefit, or whether we will, if there is any benefit, whether this will be as a result of lead time bias as opposed to a true improvement. And so I think I'll leave my presentation at that, but I'd welcome any questions. And I would like to thank Dr. Black, who helped me with the preparation of this and discussion of the topic.